some pain. And as you know, in foreign countries, they just gave him a symptomatic treatment and he was sent home. What they diagnosed was that the patient had a stomach ulcer dehydration, and ultimately it was a sepsis and the patient expired within just 3 days. So an infection which may be unnoticed or unstoppable can result in a very bad result in a patient. So this was the guidelines. The guidelines go on changing, and the latest guidelines that are published are in 2016 about sepsis, and it's a Surviving Sepsis campaign in which Indian Society of Critical Care Medicine was also a part. So we'll discuss about this guidelines and the sepsis 3 definitions. The guidelines have given 93 total recommendations, from which 32 are strong recommendations where the committee would say we recommend, and 39 are weak recommendations where they would recommend that it is we suggest. There are 18 best practice statements. Always this 18 best practice statement in this PowerPoint would be highlighted by a diamond. So remember that best practice statements. It was by 19 people task force. The names are there. You can have some of the major people, and I think some of you would have heard also this guys. It is endorsed by 31 critical care societies all over the world, and the co-chairs are Mervyn Singer and Cliff Desmond. So what's the difference between the 2002 guidelines and 2016? When I was studying, we used to have this 2002 guidelines in which we used to label initially as SIRS, which is now out of the definitions. SIRS is basically a temperature more than 38 degrees centigrade or less than 36 degrees centigrade with a heart rate of more than 90 or a tachypnea rate of more than 20, or a WBC count which is more than 12,000 or less than 4,000 with more than 10% band. So this SIRS is out. Sepsis still remains in the new guidelines. Severe sepsis word is now out. Septic shock remains. Right? So now in today's presentation we'll discuss only about sepsis and a septic shock. No SIRS, no severe sepsis. Just for your reference, severe sepsis was previously defined as sepsis plus end organ damage, and septic shock was defined as severe sepsis plus hypotension. That has almost remained the same. And now what is the definition of sepsis as per 2016? It's a life-threatening organ dysfunction caused by a dysregulated host response to infection. So there are two things. One is the organ dysfunction and a dysregulated host response. And this is what now sepsis is. Previously what it was called as severe sepsis. That is now the sepsis. What is the advantage of this new definition? It incorporates most up-to-date thinking on sepsis pathobiology and what is actually sepsis, that is what the definition is describing. But the problem is that it cannot be clinically identified. If you see by this definition, it would be a little bit vague. So what is organ dysfunction? You require some laboratory parameters to confirm that this is what is organ dysfunction. So what they have come up with is SOFA score. These are relatively old scoring system that is being used. You don't need to mug up the values because there are calculators by which you can find out the score of a patient. The maximum score is 24. That is the maximum, the 4 point. And if you see the parameters, there are 6 parameters, so it is 24. What they have done is they have included one system, and from that they are picking up and ultimately it gives a particular score. So for a respiratory system, what they have taken is the PF ratios. For a normal person, it would be like more than or equal to 400. As you go up, go down, less than 200, less than 100, which is very severe, where the patient will be on ventilator support, then the score would be 4. Similarly, for the bleeding or the coagulation thing, what they have taken is platelet, like more than 1.5x to less than 20,000. For the liver, they have taken bilirubin. When it is more than 12, then it is a very severe form of sepsis. Cardiovascular, that is the mean blood pressure. We will discuss about this MAP thing. But here, if you can see, what they have taken is dopamine, which is practically now not being used in ICUs for management of the sepsis or septic shock patients. Now it's more preference is given to epinephrine or norepinephrine. In CNS, they have taken GCS scoring. GCS scoring, everyone knows that we are doing is like normal is more than equal to 15, and the lowest possible is less than is equal to 3. And for creatine, for the renal part, they have taken creatine which is less than 1.2 to around 5. So these are the parameters on which the sepsis definitions are being based. But the problem is it has many lab tests, and you cannot, and in a resource limited setting, we may not be getting all the reports daily. So you cannot actually get a SOFA daily. You may do once, then you will be waiting for say 2-3 days, and you will be repeating all the tests again. It is a cumbersome. It's difficult. I can also not remember the variables and just calculate in my mind. It is not well known outside the ICU setting. Those who are practicing in wards may not be much aware of this. The variables and cutoffs are developed by consensus. This is not by some specific studies that they have come up with this scoring system. So what they have come up with a quick so far, that is Q so far, what is called as, and that is this. This is easy to remember. One is that hypotension of a systolic BP less than 100, having altered mental status, and a tachypnea. These three. From that, if any two or more than two, means either 2 or 3, then the patient has a very poor outcome. So this is a quick SOFA score which can be easily remembered. This is a poor man's SOFA. It's a quick and repeat. You can repeat it at any time. You don't even any lab test to confirm, and it can be used in wards. So that is the plus point of this quick SOFA score. What is septic shock? Septic shock is a subset of sepsis in which there is a profound circulatory, cellular, and metabolic abnormalities. So this is what is septic shock, and the mortality of this patient is high, like say 40%. So if you are having a patient in ICU who is having hypotension, who is on inotropic support, you need to explain this patient that your prognosis is guarded. We are trying our best. And this was the sepsis 3 definitions that have come up in JAMA, and we'll discuss this sepsis 3. So this was published from various guidelines beginning. The studies were done from 1992 to 2015, roughly 1.5 lakh odd patients from 44 septic studies. And what they come up with a conclusion are 3 variables. One was hypotension, which required vasopressors to maintain a mean blood pressure. Here we will be focusing more on mean blood pressure because there is a perfusion pressure by which the organs are getting perfused. So systolic pressure, diastolic pressure are there, but in an ICU we are focusing much more on mean blood pressure. Having a serum lactate more than 2. Previously it was a cutoff of 4. Now the lactate is 2. Lactate can be easily measured in your blood gas analysis. So if you are having a good ABG machine or your lab is having that, then you can easily measure the lactate. And so always ask for a ABG with lactate. That is what you need to specify. And if there is a sustained need for vasopressor therapy. So if there are 3 variables, the mortality is very, very high. And what they came up from the studies was a lactate level more than 2 was a good predictor of mortality. Is it a sensitivity of 82 and specificity of 22? Specificity is less, so that you need to keep in mind. Mortality is significantly higher in patients with fluid resistant hypotension. You have given some fluid bolus, still the BP is not coming up, or the patient is requiring vasopressors and the patient is having hyperlactatemia. So if there is a combination of all this, the mortality rate is 42, which is very, very high, versus only hyperlactatemia or only fluid resistant hypotension requiring vasopressors, but which is having a lactate less than 2. So if you are having all these combinations, the mortality is high, and this is by the table. If you are having a hypotension plus lactate, mortality was by studies was shown as around 42. If there was hypotension alone, the mortality was 30. If it was lactate alone, the mortality was 25. And if there was no hypotension and lactate less than 2, it's 18. So if you are getting a sepsis patient who is immunologically otherwise stable, then the mortality was less than 20%. So the chances of survival of these patients are good. So what's the difference from the old and new definition was about the lactate. In old definition, the lactate cutoff was 4, and now they have come up with a lactate of less than 2. However, there were limitations in this study was that this data was extracted from the US database. There is no Indian database as such for this. Quick SOFA and SOFA score can miss occult organ dysfunction. There may be some specific infection which causes localized collection, and they may be missed. Certain centers don't have lactate measurements, and this was on adult patients. The studies were done. This was not on children. So there are certain controversies that we cannot measure SOFA on a daily basis. Lactate should be there or should not be there in the sepsis criteria. That is a question mark. 80% of the world does not have that facility of measuring the lactate. Why not? Shock is equal to hyperlactatemia and hypertension, and patient will die if you wait until quick SOFA hits more than 2. So that was the fallacy of this definition. So always use your clinical judgment while you are dealing with a sepsis patient. Guidelines are there to guide you, but do not just rely only on the guidelines and treat the patient. So do not wait until the criteria are met, because when the quick SOFA is reaching more than equal to 2, the patient would already worsen significantly. to treat infection, oliguria, hypoxemia, etc. as indicated. In the 2012 recommendation, there was a trial done by Rivers et al. That was early goal directed therapy, and it was from that they have taken this, that what should you be giving and what are the criteria for that. So what they had recommended was a target of CVP of 8 to 12, a mean arterial pressure of more than 65, urine output of more than 0.5 ml per kg per hour, which is also known as poor man's cardiac output, and a central venous oxygen saturation, that is SCVO2. This is just doing an ABG from a sample and sending it just like an ABG, and the saturation that is shown on that ABG is your SCVO2. So these were the 4 criteria that was considered in 2012 recommendation, and this is the typical algorithm of that Rivers et al. In which if you are getting a sepsis patient, what you will do initially is give an oxygen, intubate the patient and mechanically ventilate. You think that the patient is too much tachypneic or the patient requires ventilator support. Immediately insert a CVP and arterial line, sedate paralyze the patient if you require, put a CVP, and if the CVP is less, give fluids, that is crystalloid or colloid. If the CVP is adequate, check for the mean blood pressure. If it's less, give vasoactive agents. Check for the SCVO2. If it's less, give PCVs if the hemoglobin or the hematocrit is low. If your goal is achieved, it's well. If you're not, then you can add anaerobic agents or try to find out the source of infection. So this was the Rivers et al. Study. But what now they have come up is, there were other studies that have come up, is ARISE, Process and Promise. And if you can see, this was a study was in 2001, in which it was early goal directed therapy by Rivers, and it was favoring you should follow this strict protocol. But after that, this 2014-15 studies that have come up, that Process, ARISE and Promise, they were not much in favor of you may deviate from this typical protocol of putting a lines, doing such all aggressive intervention. And this was the study. I have taken some few slides of that. What in this process they had done, they are divided into 3 groups the patients. This was basically a US based study. One was a protocol based early goal directed therapy, that is the red one. Protocol based standard therapy, this is basically for giving fluids, and the usual care. And what they found was that in the initial first all got significant amount of fluids, that was around 0.8 to 1 liter. But as the resuscitation proceeded, the amount of fluid was gradually decreased. But the usual care patients had just an average of 2.3 liters of fluid versus an early goal directed therapy of 2.8. And the intravenous antibiotic usage was almost same. What they found was that the use of vasoactive agents and transfusion was significantly less in the usual care patients as compared to the protocol based or early goal directed versus a standard therapy. The treatment has changed, but the basics of the Rivers et al. Needs to be continued and are still followed. That is, give fluids. So, what I don't need to confuse here, but the answer is that you should be careful about interpreting the results. Give fluids. The target at present guidelines, what they are saying is 30 ml per kg per hour, and see what you are getting, whether there is improvement in the BP or not. So, the basic principles of the fundamental remain the same. That is, start early, give antibiotics, correct hypovolemia, restore perfusion pressure, and in some cases little more will be required. Now these diamonds that would be coming on the slide are base practice statement. You need to remember that sepsis or septic shock are medical emergencies, and treatment and resuscitation should begin immediately. So these patients cannot be kept in ward. Once you find that the patient is having hypertension, shift this patient to an ICU or a facility where you can manage all things. You can have invasive monitors, invasive lines available, and this has to be done immediately. Source control. You need to identify where the source is. Just you are getting a count which is high, or you are getting a fever and hypotension, but when you started on antibiotic, you need to find out from where the source arises. So always find the source, and there should be an intervention to control that source. Suppose if you are getting an abscess, you are finding that the patient is in abscess at some point of time. If there is a pneumonia, then you need to try to find an anatomical diagnosis. If you can drain out that thing like an abscess, then you need to drain this thing. Antibiotics should be given as early as possible and preferably within 1 hour of diagnosing this sepsis. Initially, when you are not sure what is the organism or your culture has not come, you will be giving a broad spectrum antibiotic, and then you will be narrowing it down to the specific organism. The fluids that you will be giving is 30 ml per kg of a crystalloid within the first 3 hours. This time they have come up in the guidelines is about albumin. But I think albumin in our setup is costly, is not easily available. There were issues regarding the availability of albumin. Now it has now again come up and it's available. In all this, frequently reassess the hemodynamic status. There are non-invasive ways of measuring. Initially it was the CBP, but now what they have come up is that you can have a sonography machine and check the infraventricular diameter and find out what is the fluid status of the patient. Recommendation is using crystalloids as an initial restoration fluid instead of colloids. Suggest albumin in addition to crystalloids when patients require substantial amount of crystalloids. When you are finding that the patient requires significant quantity of crystalloid requirement. Target MAP. This is the most common question that the sisters come to and ask us. Sir, systolic BP 90 हो गया है, क्या करूं? Just the answer is, what is the mean blood pressure? If your mean blood pressure is 65, you are okay. If the patient is passing a good urine output, you are okay. So do not chase just a systolic blood pressure and try, because this is the end organ perfusion pressure where the kidneys are perfusion well and the patient is passing good urine output. Vasoactive agent choice. Noradrenaline is the gold standard and has to be preferred as the first choice vasopressor. You can add either vasopressin. Vasopressin is not dependent on the weight of the patient. It is just 0.03 units per minute. Means whether the patient is 60 kg, 80 kg, 110 kg, the dose of the vasopressin remains the same, or epinephrine. So the combination that generally we prefer is, first we start with the noradrenaline. If you are finding that on this noradrenaline also the BP is not coming up, either you can add is vasopressin or adrenaline to that patient. We recommend further hemodynamic assessment if the shock is not resolving, and determine the type of the shock just by the clinical examination. We are not coming to some clinical diagnosis and use other tools like the echo, the sonography. We suggest dynamic or static variables. So just a single readings are not important. You need to just frequently reassess, and from that you can check whether the patient requires more of fluid or more of vasopressors. Lactate. Always try to see and normalize the lactate. The second common thing that we have seen in ICU practice is that the patient is having a lactate of say 8 or 10 and you are going on giving bicarb. Bicarb is not going to help to normalize the lactate. You need to have the source control. So that is a common thing and a common knee-jerk reaction by a consultant. Lactate or the bicarb is 10 with a lactate of 8. ABG is showing a lactic acidosis. So just even giving bicarb infusion or bicarb bolus, that is not going to improve you are actually worsening this patient. So instead of that, try to improve the hemodynamics, try to sort out the things on that part, and you will automatically normalize the lactate. And we have definitely seen that if you repeat an ABG with a lactate after the 6 hours or 8 hours, and you have properly hydrated the patient, you have given proper antibiotics, and the lactate would significantly come down. Like in 6, 8 or 10 hours, you will find that the lactate has come near normal. And that is your guide on which you can say, what I am doing is perfectly okay and the patient is settling down. So screening for sepsis is, if you are not able to find out what is going wrong, then you can have this screening protocol, what we call it. And what they have found out from various observation studies, this was basically in the UK, that there was a performance improvement program, and that is what we try to follow in our ICUs also. That the nurses are taught to find out certain basic things like a bed sore which is missed. The patient has come from a XYZ hospital to a tertiary care center, and we have done an X-ray, sonography, urine RM, we are not able to find, and there is a big bed sore which is infected, and that is the source. So that is what you need to do. Always send blood cultures, and this is the commonest thing that we miss at certain level, or the consultant miss, is not sending cultures on time. Like the Mungu per se, that is the typical way. It's very costly of sending a blood culture. It's costing like 2,000 or 4,000. But you have not sent a culture. You have started on antibiotic. Patient has worsened, and then you are starting an antibiotic. Now you are sending a culture after the 3-4 days, and then you will not even be guided by culture, because now the antibiotics have also come in the picture. So it's better that when you are seeing a patient who is in a hypotension, or you are suspecting it to be a sepsis patient, send cultures from wherever sites that you think are probable source of infection, right? And what is, as per their the guidelines, what they recommend is 2 sets of blood culture. If you are having a catheter, like a Centline AITD catheter, which is say more than 48 hours old, then that has to be sent. Means the one of the culture has to be sent compulsory from that site. If the patient is not having any catheter, then you have to send from two peripheral sites. It can be either cubital vein or a femoral and cubital. That choice would be yours. But it has to be sent from two separate cultures. A single culture is not recommended because the studies have shown that the accuracy of the cultures is say somewhere around 60 to 70%. It increases if you send it from means you are sending a more bottle. The culture bottle for an adult patient requires 8 to 10 ml of blood in each bottle. And this is the commonest problem that we are leaving it to the technician or to a staff or to a nursing staff who does not know how to take cultures. Gloves na pehre hoy. It is a sterile technique, it is a sterile procedure. You need to wear a sterile gloves. You require someone else to help you out in taking a culture. If you just tell a sister to take, then she'll be touching, she'll be holding everything. So we require one person who is a sterile and another person who is unsterile. The unsterile person gives everything to a sterile person. It has to be clean with the routine things that like what we do is in the insertion of the CEP or HT catheter, clean it with the betadine, clean it with fluoxetine based solutions, and then take the culture. The other common thing is that after you clean everything, you will again be palpating that vein, confirm vein madi mana morsecond. This is a common thing that if you are not sure, you are going to puncture or you are finding difficulty in that puncturing. The other way is put a chlorhexidine on that thing. You can tell the sister, give me there, and then I touch with that finger on that vein. This is a common thing that we have observed. Even for the HT catheters, the same protocol directly starts super. They will not clean, just open the pot, put the syringe, and take the sample. So this is not the way, and then we get an organism like say cones, and we start eating that cones, which is like a coagulous negative staphylococcus, is a normal commensal. The other thing that we see on the blood culture report is that we get an organism which is like not matching, or an organism on which all antibodies are sensitive. So whenever you are getting a notorious organism or a bad organism, like Pseudomonas is considered a bad organism, and if you are getting that everything is sensitive to that Pseudomonas, then your mind should start thinking that this collection was proper or not. So this is what the cultures, there's actually a full PowerPoint presentation on how to take culture, and you should actually know that. Empiric and combination therapy using at least two antibiotics of different antimicrobial classes. This also is a very common thing that we see, that two antibiotics are running which are of the same class. Like a third generation cephalosporin is running, and along with that some near antibiotic is going on. So that is not a good practice. Either you can say like take a cephalosporin group, aminoglycoside group, fluoroquinol group. That's a combination of two different classes that you can give together. Keep in mind what organism you are going to target, whether it's gram negative, gram positive, and give antibiotic accordingly. Combination therapy is not routinely recommended for bacteremia or sepsis without shock. Means a patient who is relatively stable patient who is not in hypotension, a single antibiotic is okay initially. We recommend against combination therapy for routine treatment of neutropenic sepsis or bacteremia. Full lecture is there on antibiotic stewardship. Dr. Bhavini is going to have this as a last lecture. Empiric antimicrobial therapy being narrowed once the pathogen identification and sensitivity are established. You received a patient, you have started on a higher antibiotic, or you have started on 2-3 antibiotics, and once you have come to a conclusion that this patient is having an X organism, like say it's a gram negative organism that has been identified on the culture report, then you can definitely stop a gram positive antibiotic that you started in the beginning when you were not sure what actually you are going to treat. So that is what is antibiotic stewardship, that de-escalation or narrowing down to a lower antibiotic. The number of days that has to be given is 7 to 10 days. Just don't go on continuing for say 14, 21 days. Daily assessment of de-escalation. So whenever you are taking rounds, whether you are a medical officer, whether you are isologist, whether you are internist, whether you are a physician, just see the chart of the patient and see what you can remove from the treatment, right? Just don't, once we have started on meropenem or an X antibiotic, don't go on just bus, this will continue. So that is de-escalation of the antibiotic, which is done on a daily basis. Procal level, Dr. Bharat is going to speak on sepsis markers. Guidelines is that they can be used to support shortening the duration, the trend you need to see. I am not going to detail about Procal. And something about corticosteroids. Against, this is not to be used hydrocortisone, that is apolline. If the patient is not in septic shock, means the patient is not in hypotension, If the patient is having a resistant septic shock in which the BPs is not coming up, then what they recommended is 50 mg 6 hourly, that is 200 mg per day. For mechanical ventilation, these are some of the guidelines I am just included. Is higher peak over lower peak. Prone ventilation has now come in the picture in management of the ARDS or a bad sepsis patient in which the PF ratios are less than 150. Against the use of HFOV in adult patients with sepsis into the ARDS. Against the use of beta 2 agonist and lower tidal volume strategies in ARDS patients. Sugar control. This is one more important thing. What commonly is that a diabetologist or endocrinologist or a physician, they'll try to do a tight control. That is what is not required. You need to give a specific order that I'll be starting the insulin infusion. The most easiest and most practical thing is using a regular insulin in an ICU patient where the hemodynamics, where you don't know whether the patient is going to have an improvement in the perfusion immediately or will take some time. So you'll be starting an insulin infusion only when the sugar levels are more than 180 and that too 2 consecutive readings. The frequency of monitoring the sugars, that is also important. When the patient is initially sick, you will be monitoring every 1 or 2 hours and then you may switch over to every 4 hours depending upon the patient's clinical status. The another common thing, staff would come running and say, sugar is 36. This is a very common thing because the patient is in a septic shock, the patient is in severe vasoconstriction, and you have taken a sugar from the fingertip. What you are checking from a glucometer from a fingertip is a capillary sugar and not a venous sugar. So in that case, we always recommend that take a sugar either from a CBP, means if there is a line inserted, or from an arterial line and measure. If the patient is running on a dialysis, then the dialysis technician can also give you a sample of a blood and from that you can measure. So do not just rely on a capillary blood glucose monitoring. The best is taking a sample from an arterial blood. Renal replacement therapy. They have said that in sepsis and acute kidney injury, for increasing creatinine or uricemia without any other definitive indication for dialysis, is not recommended. So you are getting a patient who is in a having a create semi before with hypotension, then not jump to immediately dialysis. Just hydrate the patient. And I'll give you a recent example 2 days back. We received one patient who was operated for some hernia and then had gone home but came back with a poor oral intake, had not taken very well since last 1 week, tachypneic, tachycardic, heart rate of 140, BP was relatively okay, like he was maintaining a mean blood pressure of around 65, and I got a call where a patient was, and the thing was, initially the registrar was informing and the creatinine was 3.5 or 4, so the mind started the patient will require dialysis. But when you go take a history and patient and the ladies told her since last 7 days the patient was not eating well, the patient was not hydrated well, the patient was having tachycardia. So in that case, just hydrate the patient, give antibiotics, find the source control, do a sonography or CT scan, and the patient came up well. The patient did not require dialysis. Otherwise, just on a phone call, I would have said creatinine is high, you start dialysis. So that is what your clinical experience, clinical judgment, proper history taking plays a role. Nutrition. Guidelines are against administration of early parenteral nutrition or parenteral nutrition in combination with enteral feedings initially in critically ill patients. What they are trying to tell is defer the parenteral nutrition over the first 7 days in critically ill patients. Try to give when the gut is functional. That is, enteral nutritions are to be preferred initially. And initially, when you are finding that the patient is hemodynamically unstable, what you can do is start with the early trophic or hypocaloric feeds. And now the protocols and the guidelines, now what they are recommending is giving a continuous feeds instead of a bolus feeds. Pumps are available. You put a feed in that, just like after IV bottle there is IV set and which is giving you IV fluids. Similarly, there is a full bag which is filled. You can pumps are there where you can set the flow rate. Say maybe you are set at 50 ml per hour, and that pump is going to give the feeding in the rice tube at 50 ml per hour. That is much more better tolerated as compared to giving a bolus, because you are giving you eat lunch today, then no dinner directly tomorrow morning. That is a bolus thing. And if you are given a multiple slowly feeds, then you will be better tolerating. Even in a patient who is having say like paralytic ileus, studies have shown that they do tolerate small continuous feeding rather than bolus feeding. So that is a better option of giving a continuous monitoring. what again guidelines are not in favor is routinely monitoring gastric residual volumes in critically ill patients. So every time you are aspirating before giving, particularly in this bolus feeding, your staff would aspirate that thing, discards. So what you are doing is actually you are draining out the gastric juices and throwing it in the dustbin, and ultimately the patient is having problem in tolerating that feed because that gastric juice is going out. Use of prokinetic agents. Whenever you are not able finding that the patient is not tolerating feeds well, you can add either perinome and see how the patient is responding. Setting goals of care and prognosis is basically for end of life issues. When you find that the patient is in an irreversible stage or the patient is having some malignancy with mets, or where you are finding that the patient is not going to come out, use palliative care principles, and this a full team has to follow, and this has to be addressed as early as feasible. So this was something about 2016 guidelines, and maybe in 2030 when we meet, we were told whether there will be sepsis 4 definition. Thank you. Now we'll proceed for the next lecture. We have just changed the sequence of the lecture that we have given to you on the flyer. Dr. Bharat, he's an intensivist at Shrey Hospital, and he's with us since last 1 year. He'll speak on sepsis marker, and this is also one of the important area in the ICU when you are not able to find what is the whether this count is high or not. Over to Bharat.
Good morning, everybody. My today's topic is sepsis marker and its current existence.